This is my client, Katie, who drove from Dubuque, Iowa for treatment. And this is an example where someone looks like they have a sacral torsion. So if we come underneath the ILA of the sacrum, she actually looks symmetrical. If we then climb up on the lower sacrum, my right thumb is posterior, significantly so. If I slide across, I override my left thumb. And the PSISs are right here. So this is the S2 level, and then this is S1. And those are symmetrical, but as we come down to the lower right sacral quadrant, this is prominent. If motion were blocked, then I would name it a torsion. But there is research that shows that the joint can move in rotation and side bending, but it only moves a very, very small amount. And looking at landmarks, we can't tell if it's moved inside the joint. These muscles are segmentally innervated. I'll read an email from a researcher in New Zealand who talks about how muscles, the multifidi muscles overlying the sacrum, have different nerve levels. And so you could have the lower nerves facilitating increased muscle tone, and that could give the appearance of a torsion, and it could also block movement. But because she has normal spring mobility, then this doesn't meet the definition of a movement dysfunction that we name sacral torsion. The muscle tone overlying the sacrum is normal. It's equal on both sides. So this is not a sacral torsion. Let's have you sit up and face the bookshelf. So have you had any clinicians tell you that you had a torsion?
No.
Okay, well that's good. Okay. So in sitting, that pattern still remains because it's bony development. So here's lower sacrum, and this is posterior towards me. So the important considerations are that, one, a sacral torsion can be actually asymmetrical muscle facilitation. The sacrum moves so very little in rotation and side bending, less than 2 degrees of rotation, less than 2 millimeters of glide, that you really wonder, can clinicians actually perceive that very, very subtle movement? And I think the answer is no. And so sacral torsion very well might not be a pattern of movement of the sacrum, but it is a pattern of reduced motion that goes through the sacrum when you do the spring tests. And the spring tests are important because if the motion was blocked, then I would have her do the self-treatment for sacral torsion. Give me a moment. I'm going to go grab that email and I'll read it to you. So this is an email reply from Maurice Christopher McGrath, a well-published osteopath in New Zealand. And he wrote, Dear Jerry, I've written about the enigmatic, in quotation, in parentheses, atavistic, sacral multifidi, clearly innervated by the muscocutaneous medial branches of the dorsal sacral rami in a metameric or segmental manner. I agree with the idea that asymmetric contraction may well underpin the subjective observation of sacral torsion. And he writes a little bit more, a couple of big words in there, but I think you got the understanding there. So if I were to treat someone for this asymmetry, it would require that motion be blocked. And motion was not blocked with a forward spring test. So there is no self-treatment. This is the way the bone's developed. And it's important to be able to tell clients when they have a developmental asymmetry. Because so many clinicians look at alignment and make the claim that that's a treatable movement dysfunction, when in this example it is not. So thank you very much.